Good morning, everyone. We're going to talk about capnography. Capnography continues to be one of our top three largest selling products, and it's one of our more profitable ones. Actually, Palm Mask has now exceeded Amzor Plus as our most significant product from a sales dollar standpoint. So the Palm Mask is definitely something we're going to talk about continuing today. But basically, all capnography is important to us. And I had you take a look at a basic capnography training tutorial. And I guess I'll start off by asking if anybody has any, and there are no crazy or foolish questions on capnography. But just to give you a quick overview for those that did not watch all the videos, basically we inhale air that is 21% oxygen. That oxygen goes to our cells and our muscles, and we produce work when we use our muscles. The work takes that oxygen, and the byproduct or the byproduct of that work is metabolism, and metabolism produces CO2. You need to get rid of CO2. So CO2 is a waste product of the cell. It's almost like, if you will, the poop of the cell. So basically, I inhale air and I exhale CO2. CO2 has, the measurement of CO2 is called capnography, and that CO2 produces a waveform. And that waveform can be measured, and there's a number called an end-tidal CO2 number. That end-tidal CO2 number is when it reaches the highest amount of millimeters of mercury measured of CO2. So basically what's happening is a monitor is taking a sample of your exhaled breath, taking it past a sophisticated infrared analyzer and analyzing to see how much infrared light is absorbed or not absorbed, and that is basically extrapolated into a millimeters of mercury of CO2. So in essence, expired CO2 number, which a normal value would be in the 30s, like 35 or 38 if I was exhaling right now. That's normal. What we do now, most of our CO2 sales of Palm Mask and nasal cannulas and the Capnomask are all in procedural sedation or conscious sedation. So one of the first questions I'll ask, and this is kind of not necessarily critical for you to even know, but CO2 has been used in the OR to monitor ventilation for somewhere maybe 20 years. So if, and it's not critical that you understand this, but basically if I'm in the anesthesia world and I'm ventilating you as a patient and your CO2 values are like 29 or 28 or 26 and they're falling, what does that mean to the clinician? What should they do? And this is a question for $20 to somebody. So if your CO2 is low, and you may have to unmute yourself. So if your CO2 is low and I have you on a ventilator in the operating room, what would I do?
Lower the rate.
Lower the rate. Okay, and why would that be, Jerry? Why would you lower the rate?
You're blowing off the CO2 and you want to retain a little bit more CO2, so you slow down the rate of their breathing that they would maintain more.
Perfect. So Jerry wins 20 bucks. So what he's basically saying is that when the CO2 gets so low, that means that patient has been hypoventilated. They've been ventilated too much. So if they reduce the tidal volume or the rate, which is the answer he gave, you can, so you're ventilating less for that patient, and gradually they'll build up CO2. Likewise, the opposite has occurred if they had a very high CO2 reading, like a 38, 39, 42, 45, then that means they're not ventilating that patient enough. So CO2 monitoring has traditionally been used by anesthesia to adjust their ventilator and appropriately ventilate for you. it's kind of interesting. Does anybody know what they do at the end of an anesthetic case when they turn off the agents? What do they typically do to help you wake up?
Kevin, they usually try to make you breathe by elevating your CO2.
Say that again. They make you breathe what?
They make you attempt to breathe by elevating your CO2. In other words, they don't ventilate for you.
Perfect. All right. Tom Hickey gets 20. Good job. So what he basically said is at the end of a case, you'll actually see them turn off the ventilator. They'll turn up oxygen real high, but they won't ventilate the patient. They won't squeeze the bag. They won't have the bellows compressed. And what they're doing is they're not ventilating you. And they might do that for a minute or and a half or so. And what that's doing is it builds up CO2 in the your system, and it encourages you to breathe. So it starts you to breathe. So that's kind of, in fact, that's one of the reasons why you cannot hold your breath and kill yourself, because as soon as you hold your breath, your CO2 starts building up in your brainstem and it forces you to take a breath. So those are examples in the operating room. And once again, CO2 has been used for 20 years or longer, maybe 30 years in the operating room. But in the last 7 to 10 years, it's gone outside the operating room, and it's primarily now used as a no breath monitor. So you have this very sophisticated infrared system that's taking a sample of your exhaled breath, taking it back to this monitor and measuring it, and it's probably given it an Untitled CO2 number. But the clinicians that are using it for a no breath monitor are not as concerned about the Untitled number, because although it does tell them some things, because basically you are breathing on your own. So procedural sedation or conscious sedation, or procedures where they've sedated you with maybe propofol or other medications that have reduced your awareness and your ability to breathe. And they want to do that to a point that you keep breathing, but you're not as aware of what's going on. Let's say you're getting a colonoscopy and they're manipulating a scope in and out of you. It's uncomfortable perhaps, and you basically are at a state of anesthesia that is what they determine as procedural sedation or conscious sedation. So you're conscious, but you're sedated. You're breathing on your own, so they don't have a way to adjust your ventilation other than to reduce or increase the amount of propofol they give you. So we have famous people that would be alive today if they would have been on a CO2 monitor. Joan Rivers, I think she was actually on a CO2 monitor, but they didn't pay attention to it and didn't have it alarmed. They were taking pictures of her and them standing in front of her and all kinds of things, and the whole time, if they would have had a CO2 monitor on her, they would have realized that, hey, she's sedated to a point that she's not breathing. Michael Jackson would be alive today if, when they gave him propofol to help him go to sleep, they would have put a nasal cannula or a mask or something on him to tell that he is continuing to breathe. A typical CO2 monitor is set on a 20-second alert that if it doesn't sense a breath within 20 seconds, it will alarm. In the past, people have been monitoring in a colonoscopy or GI suite, for example. They've done all kinds of things. They've held their hand in front of the patient's mouth. You know, it sounds archaic, but that's the way they did it. They would be in a darkened room while they're doing this, and they would have to observe chest movement. So they're looking for chest movement, or they're looking for air moving in and out of a patient. That's how they did it before they had CO2. An emergency room example would be procedural sedation. Let's say I go into an emergency room and I've dislocated my shoulder and they want to set it and they know it's going to be painful. They would give me a procedural sedation dose. In fact, when I broke my leg and dislocated my ankle, they gave me a mixture of propofol and ketamine. And I was basically out, but I mean, wasn't even aware of them doing it, but that once again is procedural sedation. So while they're doing the manipulation and correcting it and setting it and those painful things, I'm pretty well sedated, but that stimulation is keeping me breathing. The problem in the emergency department, why they need someone on a CO2 monitor, is after they've done manipulating that shoulder or setting that foot, the sedation may still be on board and they're no longer stimulating you, and they might even leave the room, and the next thing you know, the patient quits breathing, and then you're potentially in a dangerous position. So that's kind of the overview of the training that we had. And I'm just going to ask, does anybody have any questions about capnography, end-tidal CO2? Let's open the discussion for those kind of questions.
Kevin, if it's such a critical aspect, how and why are they still MacGyvering and not using products that are designed specifically to give them better results?
That's a great question, Ken. Ken is asking, why would someone MacGyver a face mask? And I will just tell you, every anesthesia provider that goes through they all go through extensive training, but they are all trained. Every CRNA is trained to take a standard oxygen mask. So I'm going to act like this happens to be the Capnomask. So it has a vanilla scent, etc. But it looks just like a regular oxygen mask if I didn't have this sample line on it. So basically what they do, and they're trained all to do this, is they'll take an oxygen mask and they'll take a IV or a gel coat catheter that they would normally use as an IV. When you put an IV in, it has a needle in it, but then when you take the needle out, it leaves a little plastic catheter, a little straw, if you will. Well, what they'll do is they'll take that straw and they'll put the straw, they'll throw away the needle, they'll put the catheter into one of these holes, and then they'll tape it. The catheter has a lure lock on the end of it, and they'll attach their sample line to the end of that, and that'll go to their monitor. So now they have oxygen being given to the patient, and they're sampling the CO2. The problem is that, number one, if someone just touches that sample line and causes a little tension, it easily can pull out the catheter that they have taped there or they have punched in. Likewise, the CO2 is never a high quality CO2 because once again, the catheter is really small. So what it does is it gives them a waveform that kind of gives you the presence of CO2, but it doesn't give you the traditional up and down kind of sinus waveform you would expect from CO2. So why do they keep doing? Well, they are trained to do that, and they are probably not aware that there is a mask such as the Capnomask that has it all put together. I am continually amazed in this business that a great idea takes in excess of 10 years to be fully adopted. And even then you have places that continue to use the MacGyver method. So the bad thing about the MacGyver method is someone has to put it together. It's not reliable because it doesn't give you a good waveform. It can easily be disconnected. In other words, someone touches the line, and when they touch the line and pull it out, what do they get? They get an alarm that says no CO2 sensed. So they then maybe stop the procedure to see what's going on, or maybe they lower the propofol. They might make adjustments based on that alarm, and in reality, the alarm is occurring because the sample line kicked out. So the answer to your question, Ken, is why it's awareness. And I would tell you that the cost of an oxygen mask is typically, $1.20, $1.50, something like that. The cost of a gel coat catheter could be 60 cents. The cost of a sample line is like $1.50. So you put all that together and you're at about $4, which is what the Capnomask cost. Now, in our videos and training that I sent you, we also talked about the Capnoxygen mask. Now, I will tell you, we originally started selling the Capnoxygen mask 10 years ago and have a lot of customers still buying it. But our lead with product is the Capnomask now because it has a few extra features and it is less expensive to us. So when we sell it at the same price as the Capnomask, we and you as reps get a higher commission. So that's why we've kind of switched our focus to the Capnomask is the Capnomask has a vanilla infused scenting. It has a pre-attached CO2 sample line that you can disconnect if for some reason you didn't want it. It has a pre-attached oxygen tubing. And it has a filter, which could be sold at significant advantage, especially in these COVID areas. So the Capnomask has the vanilla infused scent, pre-attached CO2 line, a filtered CO2 line, pre-attached oxygen line, and they have it available in both a ophthalmic, which means that this area is cut away, so it's closer to where the metal is, or a standard adult, and they actually have it in pediatric. So in answer to your question, why do they still do it? It's basically awareness, and even if they're aware of it, it may not have gotten through their value analysis or through their purchasing. So good question, but MacGyvering still occurs, and that's a good way of asking, what do you could literally ask the customer, what are you using to monitor CO2 for procedural or conscious sedation? And they're all using a nasal cannula, but you would ask them, do you ever use a face mask? Oh yeah, we use a mask occasionally. And I'd say, are you MacGyvering that to monitor CO2? Or are you using the nasal cannula underneath it to monitor? And they're doing something like that, because if they're not using our product, they are doing something to get CO2 through the mask. Now, who can tell me what is the advantage of using a mask versus a nasal cannula to deliver oxygen and sample CO2? And it's got to be someone other than Tom and Jerry. Hey, Tom and Jerry. I cannot believe it, but my grandchildren watch Tom and Jerry cartoons. They are so violent. I can't believe it. But anyway, who can answer whatever my question was?
Is Chris Haynes, can you hear me?
Yeah, I can hear you, Chris.
Yeah, well, I mean, there's definitely the benefit with the COVID going on. A mask is much safer for the patient and for the clinicians. And then also a cannula it's easier to fall out than a mask held on securely. It's just a better system.
Okay. Well, I'm going to give you the $20 for just being bold. That was Chris, right? Chris Haynes?
Yes.
Okay. Chris, COVID is definitely the new reason you would use a mask. But in the past, the main reason they would go to a mask from a nasal cannula is because a nasal cannula, and I'll ask this question, what is the average FiO2 range of a nasal cannula? To anyone but Chris or Tom or Jerry.
32%.
And who was that? Bill Thomas?
Bill Thomas.
I would say 32% is too accurate. I'm not positive that's correct, but basically in the 30s. I don't know whether it's ever been measured precisely that, but nasal cannula is typically in the 30s, and a oxygen mask is usually double to even higher than that. There's studies on the palm mask that says it does 93% FiO2, and I've had some people doubt that, but at any rate, the point is the nasal cannula delivers in the 30s. An oxygen mask delivers significantly more. So typically when an anesthesia provider would use a mask versus nasal cannula is perhaps with a morbidly obese patient, somebody they're going to be concerned with that they may not be able to get or keep their O2 saturation up. In other words, get as much oxygen as they can. So they might use a mask instead. I've seen some people where they use a nasal cannula, and then they'll put the mask over the nasal cannula, and that kind of keeps oxygen, increases the level of oxygen. But part of the reason also is that there's a limit to the amount of, you have a flow meter that's usually 0 to 10 to 15 liters of oxygen. With a nasal cannula, I believe you're limited to somewhere in the neighborhood of, I don't know, maybe someone knows, but I think it's 3 to 6 liters of oxygen for a nasal cannula. And it can't go any higher than that. Whereas with a mask, you can go up to 10 liters of flow or even higher. So in general, a mask will give you higher FiO2 than a nasal cannula. It'll give you protection from COVID. And if they use it in the PACU, it protects everyone else from COVID. So that's kind of why we think we should get an increased, just like we're getting an increase in sales with the Palm. I'm encouraging everybody that has a new Palm customer to try to get them to sample our Capnomask, because I think they are hopefully an easier sale for us. Okay. Okay. So do we have any other questions while we're talking about the Capnomask? So Capnomask is a great product. We make more money on it than we do with the Capnoxygen. It is vanilla infused. The only time you would sell the Capnoxygen over the Capnomask, I believe, is if you're selling to anesthesia and they tell you for some reason they don't want a sample line because they already have a sample line hanging from the machine. The Capnoxygen mask comes with a sample line as an option, but most of the ones that we sell just have the lure lock there. I think I have one here I can show you. It's not handy here. But at any rate, so it just has the lure lock to be able to attach. So if a customer said, hey, I don't need a sample line, the Capnoxygen mask would be a good option for them. Otherwise, I would go with the Capnomask because it has the other advantages of being vanilla scented. The vanilla scent, some people love it. Some people, it's no big deal. It's a faint scent, but it's designed to make a patient more comfortable than if they were breathing a plastic smell. Okay. And there are some studies that aromatherapy reduces post-operative nausea and vomiting or PONV. So most people don't object to the fact that it's a scented mask. Okay. Anybody else have any questions about really anything to do with capnography?
Hey, Kevin. Can you,
yeah, John?
Hey, I've been getting some good orders from since COVID-19 on Capnomask because it provides a protective it protects against aerosol pathogens and germ spreading and a protective barrier since COVID-19. So a nasal cannula still is a good option, but a lot of these hospitals are looking for protection. And so I've been getting some good orders in the past few months on Capnomask.
John, have you got Capnomask for patients or for customers that are already using the Palm mask or just in general both?
Both.
Okay, good. Well, let's talk about the Palm mask for a second. Does anybody else have any questions? Okay, I have the Palm mask in front of me, and this is for a $20 question. Who knows which model of Palm mask I have in my hand? And I will tell you it has an O2 connector, it has a reservoir bag, it has a sample line, male to, oh, actually this one, yeah, this one is a male-to-male sample line. Does anybody know what product number this would be? Not from Bell, but let's go with the product number from Palm.
1001 mm.
And who said that?
Ken Stinson.
Hey, Ken, you are right. You're a winner of. Okay, and Ken, can you tell us why you know that that's what it is?
I've just committed it to memory.
There you go.
The 1003, you're going to have your MSAs. Well, the 1001 has the reservoir bag, and then but the 03 is slightly a few dollars less, doesn't have it.
Yeah. The key difference is the reservoir bag. So Ken is correct. Ken, I appreciate it. There's one other thing that I would emphasize, and why I emphasize the 1003 for anesthesia is the 1003 comes
fully assembled.
Assembled, thank you. It comes pre-assembled. So it has this already pushed into it, and it has the oxygen. So it does not, so 1003 does not have the reservoir bag. It has the sample line pre-attached to it. So when you come it out of the package, it's ready to go. There's no assembly. Whereas with the 1001s, you have a choice of, do I want to use an oxygen tubing directly into it, or do I want to use my reservoir bag? And most of all sales have been done with the 1001s. Most, I'm going to say maybe 70% of ours is 1001, because that's what we started selling. And I don't have a problem selling that, but if you're selling the anesthesia in the GI suite, you know, it's worth asking them, would you like the reservoir bag or not? Or I would just recommend the 1003, because once again, they love it when everything's pre-assembled. The only time that the reservoir bag is really an advantage is maybe when you really need high-end FiO2 on a morbidly obese patient, perhaps, maybe for an ERCP or an EUS procedure that's going to take a long period of time. But in general, anesthesia does not conserve oxygen. They're happy to dial in 10 and 12 liters of oxygen flow through this tube. So that patient can get as much oxygen as they can take in, basically. Where the reservoir bag really becomes an advantage is if you were concerned about oxygen and you only wanted to deliver 3 liters of oxygen. And what happens is when you're exhaling, when I'm exhaling, this is filling up with oxygen because the 3 liters continues to come. And then when I take a breath, I'm able to take that breath not only from the oxygen supply that's coming in, but also from the reservoir bag. So in general, the 1001 gives the user a choice to assemble it with the reservoir bag or without it, but they have to assemble it. The reservoir bag, I don't believe is needed. So if you come across any customer that's using Trianum, they're probably selling the 1001 with the reservoir bag. And you could, if you have a clinician there, I would ask him, do you use the reservoir bag? Do you like it, or would you rather have the device pre-assembled just with oxygen tubing? You know, if you aren't with a clinician and you're with more of a buyer, then you would say, hey, I have guaranteed savings over Trianum on the palm mask. Here's our 1003. Now, you would use our B numbers, but you would quote them the B number that's appropriate with the 1003 mm. And 95% of the customers use male-to-male connector. I'm going to say, you know, the other 5% either uses a male-to-female, or they use an Iridian or microstream connector, which the orange piece with the reflected. It's relatively small that do that. Do we have any questions on the palm mask? I'm telling you, there is, we've done, it's now our most popular product, and I don't believe we're close to the end. So if you're late to jump on the palm bus, that's okay. You have customers out there that are either buying it from Trianum, that we should be able to take that business, or they're never even heard of it. And when you show it to them, they're going to be very happy that you had. So the question when you're talking to on the phone with an ambulatory surgery center person is, do you do upper GI procedures? And if they do upper GI procedures, then they're a candidate for the palm mask. And if they say, yes, we do upper GI procedures, and you might say, well, have you gotten to try the palm mask or procedural oxygen mask? And if they say, I'm not sure, then just get their name, their email address, etc., and we'll make sure they get samples. And I would send them samples of the 1003 mm, even if you don't know what monitor they have. It's nice if you got the right person on the phone and they can tell you what monitor they have. It usually tells you and confirms to you that they would use a male-to-male connector. But once again, 90+% of the monitors out there have a female Lurlec on it. And even if they didn't and they got a sample of the palm mask, they still would be able to see what the palm mask was all about. They would always have their own sample line that they can connect to this, and they would at least be able to use it. They would say, hey, everything was great except we don't use that sample line, you know. So you still can get away with it. So the key thing, though, is that you need to send out samples through Joe Voss on a weekly basis. John Lohr was, again, our sales rep of the month. He's been consistently the sales rep of the month throughout 2020. I think almost if not every month, every other month. And it's because he consistently sends out through Joe Voss samples to 2 or 3 customers every week. And that the compound effect of that is that he's always got business in his pipeline. So basically, he's prospecting on a daily basis, trying to get people's addresses, names, etc. And that's what Joe Voss needs. He needs the name of the person at the surgery center, the address, what kind of product you want to have sent, and that's really all. So he's been very successful. So keep it up, John. Any questions on the palm mask? Any questions on capnography in general? All right, we're going to talk for a brief moment on our Comfort Soft nasal cannula. And what I encourage you to think of on this product, first of all, this is private labeled, so it says Bell Medical on it. We have this exclusively everywhere, and it kind of protects you from other cannulas that could even be the same material. But Bell Medical has this private labeled for us by a company called WestMed out of Mexico. It is by far the best nasal cannula on the market. Now, why would this be the best nasal cannula on the market? Who wants to tell me why it is? That hasn't gotten 20 bucks yet.
Ouch.
Who wants to tell me why this cannula would be of interest to somebody at the largest IDN, that they may service?
Because it delivers oxygen and monitors CO2, stays in place, very comfortable, won't dislodge, great pricing.
Okay. Why does it stay in place?
You get a little extra, it fits real conveniently behind the ears. You got a little extra room. If your patient's over on the side, you've got a little more space.
Okay. And why would it be a product that would be something that an IDN would like to standardize on?
I'll let somebody else answer that.
Okay. Who was that, by the way?
It's Ken.
Ken again? Ken Stinson?
Yep.
Okay.
Well, hey, Kevin, this is Jerry. The little adapter that will allow them to connect to either a male-to-male or male-to-female. So depending on, it doesn't depend on what monitor you've got, unless it would be a Iridian technology. But that in itself would allow an IDN to have it available to everybody.
I would agree with that. So good job, Jerry. So for those that, I don't know whether you can see this or not, but that is a male connector. And, some people have trouble understanding why that's a male connector, but it's all about the middle piece is sticking out, and then it goes into the female end. So this would be a female connector. Okay, so male connector, female connector. The little inner part goes in, and it's a lure lock because it twists and turns and locks in place. So what Jerry was referring to is the reason why our system is superior than anybody else's, and no one else does this. We put this in every nasal cannula. So basically, we have 2 SKUs, plus we do a 10-foot cannula. We don't even do a 7-foot cannula. Salter is one of the companies that leads this business, and they must have 25 SKUs. And one's a male connector, one's a female connector. One's 7-foot, one's 10-foot, one's 14-foot. One has this male connector coming off just a little bit, way by the cannula for some reason. So they have all different options. We have basically, on purpose, we only do a 10-foot and a 14-foot. They all come with this male connector, but they all come with this adapter that allows you connect the female and then end up with a female connector. So Jerry's right. This device, this nasal cannula will work on every monitor that's out there except a microstream, the one with the orange reflective sensor on it. So the point is that a large IDN could standardize on this. Now, why is it called Comfort Soft? Because this tubing is significantly softer. Now, almost every competitor, even Salter, and all of them are coming out with some form of softer tubing. But this company that we use has made it. They made it first. They made it longer. They made it so it doesn't kink, so it's kind of like a star tubing. But basically, what it does is when you put this on and put it around the ears, it's more comfortable, perhaps. But you know what, that's not that important because, to be honest with you, in procedural sedation, which is where you would use this, we're not using this as an oxygen cannula that you would have on for 3 days in a row or maybe for 3 weeks in a row. This is used for procedural sedation because you're monitoring CO2. So this one might cost $1.50 to $2.25, whereas an oxygen cannula might only cost 50 cents because it doesn't have this sample line. So we're using this for procedural sedation, so it's really not even on a patient that long, so that patient comfort is not that big of a deal. But it's still, these days, why not have it be more comfortable? But the key thing that Ken mentioned is it doesn't pop out here. So the other tubing that people have is stiff, and when it's stiff, it sometimes pops out over the ear, and then the next thing you know, this comes out, and maybe they're under a drape and they're doing some kind of surgery, and the next thing you know, you get a CO2 alarm, and the CO2 alarm basically is letting people know that the patient's not breathing. And in reality, they're breathing. It's just that this has gone out of their way. So, hey, I may lose everyone because we're on Zoom and I only have 40 minutes. So that's kind of if I lose everybody all in one abrupt moment, that's what's happened, and it's A-okay. But the other aspect to be aware of this is what's called a split cannula. So one side does oxygen and one side samples CO2. But Comfort Soft means this tubing is soft. It adheres to the face and does not get dislodged easy. So combination of male and female, Comfort Soft, split cannula, oxygen, 10 foot in length. We do better than everybody else. And we can sell this down all the way down to $1. We don't want to go down there right away, but we guarantee customers a minimum of 3% savings, and lots of times we can save them a lot more than that. Okay, so since I know we may get cut off because that's the way Zoom works, does anybody else have any additional questions? We've talked about POM, we've talked about Capnomask, we've talked about nasal cannula, we've talked a little bit about Capnoxygen. Anybody else have any other questions they want to throw out there? Okay, well, that's all we have for capnography today, and we're going to try to have more general education sessions like this. Hopefully you found this helpful in regards to that I sent out videos for you to watch, and then we can have this discussion. Has that been good for folks?
Definitely.
Thank you.
Been really good, Kevin.
Thank you, Kevin.
Absolutely.
Hey, Kevin, I noticed that there's 2 questions on the chat feature if you want to take a quick look.
Thank you. Chat questions. The oxygen flow rates, the number that we dial on the oxygen flow meter between 1 and 15. I did say we can go down for $1, but you got to have a pre-approval from either David or myself or Joanne. I'm not sure what those other questions mean, but FiO2 means the amount of inspired oxygen.
We cannot sell it at $1.
Oh, we cannot sell it at $1. I apologize.